And I'd like to have my colleague at Adult Mental Health Division, Belinda Danielson. As we both lead off, I'll give just brief introductions. I'd like to do for myself and then also Belinda, and then we'll go ahead and get started. So for those of you who do not know me, well, hopefully a lot of people do. I've been with the department for a long time. I'm Dr. Jared Euro. I'm Chief Clinical Officer, Clinical Psychologist Supervisor, and currently Acting Public Health Program Manager for the Treatment and Recovery Branch at the Alcohol and Drug Abuse Division. Have been with the Department of Health almost 29 years, the entire time with the Behavioral Health Administration. That's included work with Developmental Disabilities Division, Child and Adolescent Mental Health Division, and for the last 20 years with Hawaii ADAD. And now I'd like to go ahead and turn it over to Ms. Belinda Danielson.
Aloha, everyone. Good morning or afternoon. Oh my gosh, it's noon. Okay, sorry. The day just went by really quickly. I am with the Adult Mental Health Division, sister division to ADAD, and we deal with our individuals with serious mental illness. And I am out of the peer branch, which is a performance, information, evaluation, and research branch. I am the community program supervisor, and basically what I do is oversee contracts that we push out to our private contractors in order to serve our population with mental illness and co-occurring. And I oversee our crisis services, so that's why I'm here today, as Hawaii Cares and 988 are under my privy, and I look forward to sharing good information. We've got a great team, both partners that are involved in Hawaii Cares, so we rather give it over to them to kind of get into the weeds, if you will, and talk about that smooth transition. Thanks for having us.
So could we go ahead and have sharing of our slide presentation, and then we'll give kind of a brief intro, and then we will ask our team to take it away. So one of the things I at least had wanted to note in our presentation is actually what makes up Hawaii Cares is really a collaboration between Adult Mental Health Division as well as the Alcohol and Drug Abuse Division of the Behavioral Health Administration within Department of Health, and two agencies who are very happy to have as our partners with us. Adult Mental Health Division contracts with Care Hawaii, and Alcohol and Drug Abuse Division contracts with Aloha United Way 211. So collectively, we are Hawaii Cares or Team Cares. And so we work together in order to be able to make sure that individuals who are in need of mental health or substance use disorder services have a place to go when they call in. So what I'd like to go ahead and do now is turn it over to Brian Morton of Care Hawaii, who is going to go ahead and provide a lead-in and description, because when calls come in, they do go into our Care Hawaii partner first, and then afterwards, those calls, if they are of a SUD or substance use disorder nature, go to Aloha United Way. So I would like to go ahead and first turn it over to Brian Morton, and I will let Brian, you can introduce your team. Mahalo.
Hi, how's it going, everyone? My name is Brian, and at the moment there's going to be Sasha and Dennis presenting for Hawaii Cares on the call center crisis site.
All right, I'm Dennis. I've been with the crisis line from its inception. This August will be 20 years for me. I actually worked on Belinda when we was the suicide crisis line. And now we transition over to Care Hawaii. So we will be taking all the calls that's coming into the call center.
Next slide, please.
So basically, when a call come into the call center, so we basically triage in that call, whether it's for crisis, mental health services, substance abuse. We would screen that call. If it's for any crisis services, we go ahead and address that consumer when they call in. So if they're in a crisis, we do a crisis risk assessment on that individual. And also we have what we call CMO, that's a crisis mobile outreach that we actually can dispatch out to the community to that individual, and they can go anywhere. They can come to the hospital. I'm sure you guys are aware of that. They can go anywhere within the community. We go to schools, in park settings, anywhere in the community, and we do this for all the islands. If that individual is not particularly in a crisis, just maybe needing some substance abuse, getting into a program, that's when we would give a warm handouts to our substance team over there, AUW. Our great people is over that side who actually would take that call. We give a warm handout, so we would actually gather the client's information, get a name, contact phone number, just in case they get disconnected, and then we'll hand them off over there to our substance team to go ahead and assist that client.
So we also provide services for the adolescents and adults statewide, as Dennis had mentioned. We also receive phone calls from NSPL 988, which just recently came out July 16. We also are gearing up for text chat, which will be starting up September 1st. So other services that we do provide and that we do screen for is CSM. CSM is temporary case management for 30 days. If the consumer is not linked with mental health services, a CMO can be dispatched to link the client for mental health services, 30-day case management. Through this interim, the consumer can be linked for housing, benefits, financial benefits, and some other resources such as psychiatrists, medication, therapy. Another service is LCRS, which is the Licensed Crisis Residential Service Facility, which we're able to stabilize a client who's feeling suicidal, needing therapeutic support, crisis intervention, medication management, relapse prevention. Next slide, please. So this is just a slide that shows you what CMO does. Like I said, CMOs, or what Dennis had mentioned, CMOs goes out in providing services to help stabilize the consumer and linking them up with services that help stabilize the situation. Next slide, please.
So we're trying to run through this real quickly so AUW can get theirs in. So we have any questions at the end, you guys can ask us for further details. But when they call into the center, we do a risk assessment. So basically, like I said, we triage in that call. We're trying to see what's going on with that individual, you know, especially if they're having any suicidal thoughts. We want to find out the level of lethality. But of course, we can only gather so much information over the phone. And that's why we dispatch a crisis mobile outreach worker to go out into the community to do a face-to-face assessment, because they have up to 4 hours with these clients. So they can evaluate their client a little bit better to see if they maybe can get them stabilized in the community. And like Sasha mentioned, maybe they have to go to the LCRS. And we do have the stabilization beds also now at Waikiki and also at Ikolu. And that might be a possibility for the clients going there as well. But we can also, when that CMO is out, they may determine that individual may need a higher level of care to go to the hospital. So that's the purpose of the CMO going out to do the face-to-face assessment with the client. And we're available 24 hours, 7 days a week for that, for the CMO to be dispatched if they have to go out. Next slide, please. And we have to remember that these resources that we are giving these clients are limited resources. Is for crisis intervention. So when the CMO go out, they can link these individuals up if they are agreeable to it, to what we call CSM, that's crisis support management. So it's a temporary crisis case manager to assist that individual with further linkage to community resources. Whether some people may just need help with getting a bus pass, whether they need to get SNAP services. So a different array of services that CMO can explore with that client. Sometimes they might go out and say this individual may be in a situation, they just homeless and may need to go to IHS, or individual may be in a domestic situation where they might can assist them and advocate for them going to domestic violence shelters. But one of the things they can do also, if they need long-term mental health services, the CSM can assist that client with, if they don't have any medical insurance, they can help them link up to Quest, whether they can try to go ahead and get the 1157 done to possibly get a long-term behavioral health case manager.
Aside from CMO services, CSM services is also a benefit for the consumers, because these are some of the services that allows the client to have a face-to-face, and the CSM is able to walk through certain situations with the consumers, whether it's filling out the MedQuest or EBT applications, because a lot of these consumers, they get overwhelmed, they get just in distress, they don't know what procedures to follow. So CSM is one of those perfect services that allows the worker to walk with the client. This is also another service that we would partner up with AUW should a client seek substance abuse treatment. This is a perfect service that would support linkage, coordination for the client to get into treatment. Next slide, please.
And the LCRS, our licensed crisis residential, like we said, that's for observation. Mostly we want to get a client there to help them get stabilized. When they're in the community, might be having some kind of mental health break. And it is for people that's having a mental health break. So the initial stay is for 10 days. So we want to help that client get there. They do have a nurse staff there to help the individual, to help monitor them. So it's not a long-term thing. So basically, we're just sending them there to help get them stabilized. And hopefully, if they don't have a case manager, help them link up to a behavioral health case manager to look into things like long-term housing and that type of thing.
Excellent. Again, LCRS is used for medication stabilization. Let's just say a consumer changed their meds, they're symptomatic, or they're having side effects. This would be a perfect place for them to get stabilized. Mood stabilization, relapse prevention, as I had mentioned earlier, and also to prevent a psychiatric emergency. Prevent psychiatric emergency is the client being admitted into the mental health, behavioral health unit. Next slide, please.
And so, as I talked about earlier, we do have our stabilizations bed that we work with over there at Ecolo and the Waikiki Beach side. And basically, it's the same for mental health break. So the client may be eligible to go there. We would do the same. We would take information and put the information in to see if they meet criteria to go to the stabilization beds. You know, basically it's for the same thing. We want to make sure these clients are being stabilized and not just thrown out there to the community. And one thing we wanted to prevent is hospitalization. You know, if we can help do that. And at any point, it could be some dual diagnosis going on, mental health behavior. It could be some substance issues as well. That's why we work closely with our substance side to make sure at any point we can help get them linked up to that services as well. We do have the Waikiki Beach side that's there. We have Ecolu, and we have one in Kona also. And on Hilo, we have the licensed crisis residential on the Hilo side. That has 8 beds. And on Maui, we also have 8 beds for the LCRS. And on Oahu, we have 16 beds for the LCRS.
And how many on Kona, in Kona?
There's 8.
8. And where's Ecolu?
Ecolo is in Kaneohe below the state hospital.
How many beds there?
They have up to
17.
17, yeah.
17.
Excellent. Oh, very exciting. Oh, one more question. Oh, that was it. Thanks.
Yeah, next slide, please. And that concludes our portion, and we pass it over to Josh and his team.
Oh, we have another question. Who staffs the crisis mobile outreach vans?
What was that?
Can you
Staffs the
I'll take that one. So
Correct.
they're not vans, they're individual crisis mobile outreach crisis therapists who go out and meet in the community. So Hawaii Cares would dispatch them, and they're in their individual car. So whatever vehicle they're in, they'll just roll up and meet the individual in crisis wherever they are, and try to engage them and try to stabilize them back to the community, or try to identify what best meets the needs of the person in crisis at that time. So yep, just your average Joe, qualified to provide crisis intervention in the community. So it takes them about 45 minutes to get there and assist the individual.
So this seems like a big workforce you'd have to cover 24/7 on all the islands. Yeah, how many crisis outreach managers do you have?
So that is a different contract and a different provider. So we would ask them that question when, if you folks choose to invite them to your next, to your next, brown bag.
Sure. Leilani wants to know, do they work in teams? And, so maybe we've got a lot of curiosity about them. Are they all therapists, LCSWs?
No, they are all what we call mental health workers. So bachelor's level with substantial training in various, crisis related topics and issues, but they are managed or supervised by a qualified mental health professional. So a licensed individual is always you know, they have access to that person immediately if they need to consult on a case. And unfortunately, they go on their own. So they're tough. There's some tough folks who are willing to respond to any case, solo. But Hawaii Cares does a really good job of trying to assess for risk and try to make sure that the situation is safe for the outreach workers. So that falls on Hawaii Cares to make sure that they're screening for safety for our crisis
Yeah.
mobile
I
outreach.
was thinking they got to be really tall.
Really big, a lot of them aren't. A lot of them are women, and we got to give them kudos.
Wow.
Absolutely, kudos to them.
Yeah. Okay, thanks.
Well, and Brian and team, thank you so much for your presentation on behalf of Care Hawaii. And now it is my pleasure to turn over the presentation to Jennifer Peacher with Aloha United Way. So take it away, Jennifer.
Hi, aloha everyone. My name is Jennifer, and I am the Senior Director for 211 Community Response Programs at Aloha United Way. And what that means is that I lead the department that houses both the 211 Information and Referral line, as you know it now, and also this new SUD program and this partnership with the CARES Continuum. So we're really excited to be a part of the continuum and to have started in April supporting and managing SUD clients. So I'm going to let Josh introduce himself. He is our program and evaluation manager. So he'll be on next.
Thanks, Jennifer.
I guess next slide, yeah, Josh?
Sure. Yeah.
Okay.
Yeah, and also there's a couple of others of our staff here on the call, so I'll also have them do some quick intros. But my name is Josh. I'm the program evaluation manager, and basically what I do is I work with Jennifer and our leadership staff to ensure that our coordinators, the ones who take the call, are well supported. We use data to make some really critical decisions on how we improve our policies and procedures. So we're really excited to meet with you all, and this is a really great opportunity to talk about Hawaii Cares and the impact that we all have on the community. So one of my colleagues is actually Elliot. Elliot, you want to give yourself a quick intro?
Sure. Hi, everyone. My name is Elliot. I'm the clinical manager for Aloha United Way, the SUD program. And I will turn it over to who's here, Alec?
Yes. Hello, everyone. So my name is Alec Corneo. I'm with Aloha United Way, the SUD CARES program, and I am one of the SUD care coordinator supervisors. So I work with Jennifer and Josh and Elliot to best support the care coordinators as much as possible. So yeah, nice to meet you all and very excited to be here.
Thank you, Alec. And we also have Zuri.
Thank you, Josh. Hello, everyone. I'm in a brown paper bag in honor of our meeting. My name is Zuri Bender. I'm the training supervisor for Aloha United Way 211 Community Response.
Zuri, that should have been all of our background for this brown bag lunch. So we're really excited to present to you all. And so we'll just start at the top real quick. So if you don't know AUW or Aloha United Way, AUW has been around for over 100 years. And truly our mission is to bring people together like yourselves to really work with, on some of the toughest challenges our communities are facing. So we work with not just the public sector, but we work with the nonprofit and private sector to really work on health, housing, and the financial stability of all of Hawaii. So even though AUW is here on Oahu, we actually provide statewide services. So from Hawaii to Big Islands, we truly try to reach all parts of Hawaii. And we do that through our partnerships. So we work with about 1,500 companies and more than 300 nonprofits to really work on these larger issues that are impacting our community. Next slide, please. Thank you. And then started in April, we actually had a new partnership emerge with ADAD. You just want to, you could press maybe 2 or 3 times, so it'll show us the text. So April, we started to take the SUD calls. And in fact, if you're familiar with 211, the information and referral line that I know Jennifer put some information in the chat, we actually replicated the 211 model for this SUD program. So our goal is to provide information and screening for all Hawaii residents who need SUD treatment and recovery services. Can you press the next little thing there? We have some more text pop up. So we aligned the 211 information and referral line with the SUD line. So if you have clients that are in need of SUD assistance, they could receive it 7 days a week, Monday through Sunday, 7 a.m. to 10 p.m. You can reach one of our coordinators that will be there to help answer any questions you might have or one of your clients might need when it comes to SUD support. And also, we just want to really emphasize that this is a tailored program just for SUD. So, you know, through the gracious contract from ADAD, we're able to hire about 15 folks just for SUD. So truly, this is a great impact that we want to have for the SUD community to really address the needs for the people that have and need SUD services. Next slide, please. Okay, thank you. And then really quick, so we just wanted to go over some of the procedures. Care Hawaii kind of explained a little bit of that, but I just want to spend maybe 2 minutes talking about how calls get to us. So Care Hawaii is there, and Care Hawaii Cares is around 24/7 to help with that initial triage. And you know, through now 988 and also the 808-832-3100 number that you might know of. Can you press the next 2 times? So as you know, Care Hawaii manages crisis and mental health, but now with AUW 211, you could think of us as being the substance use arm of Care Hawaii. Can you press the next slide, please? One more time. Thank you. Okay, so so with this new contract with ADAD and 211 and AUW, we'll receive the call from clients either from Care Hawaii or a direct call from 211. And if a caller is ever in crisis, we develop a lot of procedures and protocols where we want that to be seamless, so that if a caller is in need of mental health or crisis supports, they could be easily transferred and get the help they need for their immediate crisis needs. Can you press the next button, please? Thank you. And then I think one more time. Aha, there it is. Okay, so if you ever call 211, there's various options that we have. 211 offers a lot of supports for clients, from health and housing to COVID vaccines. And with this new arm of SUD, returning clients. So if you're familiar with WITS, any of our clients that are in the WITS system, and you know, we do a screening for them. We want to make it really easy for them to get the access and care that they need. So they could go ahead and just call 211 and press 7. And same thing with our providers. We want to make it really easy for folks. So providers can go ahead and call 211 and press 8. So you could get a hold of us, and we could better get the triage unit for the clients. Can you just press next, please? One more time. Awesome. So we just want to show you a little bit of what happens when someone calls 211 and what our coordinators will do. So we'll do a USIS screening, which is called the Universal Standardized Intake and Screening. So ask some questions when it comes to health, when it comes to mental health, their substance use needs, and also general basic demographic information. We'll assess their needs based on where they are on the islands, and then also, what they're presenting. And then can you press next again, please? And then one thing that I think is just really great that separates this contract from the previous contract is that as we know, clients who are in need of SUD services might also need other kind of supports. So with the 211 program, if they are in need of health insurance, if they are in need of food support, housing assistance, and other kind of health and human service needs, we could make that contact really easy and transfer to the 211 folks at the other side of 211 to really help triage them when it comes to their other health and human service needs. If they need Medicaid and those kind of checks, we'll conduct those as well. So it's a really great opportunity to help the clients in a holistic manner. So, and then if you could press next and next, it will take you to the next slide. And I actually want to kick it off to Elliot, who's going to talk a little bit about our clinical services and our program. Next slide, please. And then Elliot, I'll let you take it away.
All right, thanks, Josh. The SUD cares providers, universal substance use disorder screening, care coordinator, referral, placement determination, linkages to appropriate ADAT contracted treatment providers and non-ADAT providers. This is basically what we are doing when we receive a call that is normally transferred from the crisis line to us for SUD services. The care coordinators are doing that USIS form that Josh was talking about, and we're working with them to determine what their needs are through doing that USIS form. Normally, we are referring them for a substance use assessment to determine whether they need SUD services or treatment, and if so, what level of care they need. So we'll take down their information, we'll refer them to a provider, and the provider will then schedule a time to do an assessment with the client. Usually within a week or so. They're pretty good about getting the client in to do the assessment. The provider will then send us back. I'm not sure, can you hit enter again? I'm not sure what is next on this screen. Yeah, so when the assessor completes the assessment, which we call the bundle, it's the ASAM level of care, the dense ASI treatment plan. Usually they don't have the treatment plan until they've been in treatment for a couple of weeks, but basically we're going to get the ASAM and the dense ASI and to determine what level of care the client needs. Then we will refer them to the appropriate service provider, whether that's residential, OP, IOP. Okay, next slide. Authorized client SUD statewide services for early intervention. This is basically what I just said. Sorry, I was moving on too fast. But we will be sending them to the appropriate service provider. So the care coordinators, one of the things I wanted to emphasize is that we're not just a call center where we take the information, we make a referral for, let's say, an assessment, and then we're done with the client. We're also following up with the assessors to ensure that the assessment's being completed. They will send it back to us. We will review it, send them to the appropriate treatment program, and then we will follow up. It's called in our referrals out, we will follow up within 3 to 5 days to ensure that the treatment program has accepted this client and will be providing the needed service. If they're unable to, maybe they have a long wait list or whatever the case may be, we can then determine whether we should send the client to another treatment provider so that they won't fall through the cracks or have to wait too long for the services.
Can I
one
just
of-
ask you a question?
Sure.
So you said most of the providers could see patients within the week, and then the bundle sounds like it takes 3 to 4 days maybe to get the bundle done, or how long does that usually take?
Usually within a week. It depends. I mean, sometimes we have a lot of clients who are in OCCC, for instance, so it might take longer to get in there based on their COVID count or whatever their scheduling is. And then getting the assessment back might take a little longer. But if it's just on the regular basis, within a week, they will usually do the assessment. And then within a week or 2 at the most, they will be sending us back the assessment or the bundle.
Great, thank you.
Okay. And one of the other things that we do in the SUD here is benefit exceptions. So we're working with the ADAD treatment providers throughout the state. Oftentimes a client will be in a particular level of care and may need a little longer in that level of care to hopefully solidify their sobriety and give them the skills needed to remain clean and sober when they leave treatment. At that time, the provider will be sending us what we call a BE or benefit exception. So they're going to send us a bundle, and they're going to justify why that client needs to stay in a particular level of care for a little longer. You know, usually the insurance companies, their funds have run out at this time. So they're basically asking ADAD for funding to keep this client in that level of care a little longer. And we will review the documentation to ensure that it's clinically sound and that it's justifying that client staying in that level. If so, then we approve it and they can stay. It's usually requests like 30-day or 30 units at a time. Okay, next slide.
We do have another
Yeah.
question, if you don't mind.
Sure.
What is the expected time frame between initial phone call and residential placement? Are there any work groups focused on decreasing this time frame?
That's a great question, which I have no answer to. I mean, we do have a work group, you know, on every Thursday with ADAD and with the providers, and that's usually the topic. Is that, you know, we don't have enough bed space in the state. The bottom line, you know, we can get the okay. Go ahead, Dr.
Yeah, and I'd like to go ahead and answer this. And I think this has sort of been one of the challenges both nationally and globally. I think if any of you have been following what's been happening as a result of the pandemic, as well as I guess what could be called the silver tsunami of retirements, we have had a challenge overall, really in terms of workforce. And so for any of you who may have been either working at residential programs or having challenges, this seems to be the state of the field globally. I know this through my work nationally through NASADAD, the National Association of State Alcohol and Drug Abuse Directors. I know this recently from hearing from a gentleman from the United Nations World Health Organization. I know this through SAMHSA, the Substance Abuse and Mental Health Services Administration of the U.S. Department of Health and Human Services. What we're seeing in Hawaii is we know is happening everywhere. And so one of the things we are doing is we are looking at workforce. This is sort of the holy grail right now. We are trying to do things to look at how can we go ahead and retain the workforce we have, as well as also recruit new workforce, because for the younger generations, we're aware that there are issues with regards to pay, benefits, salary schedules, opportunities for growth and advancement in the field. These are having tremendous impact in terms of who works at a lot of our, I would say, health and behavioral health programs. So we are doing everything we can. I can tell you there are task forces nationally and locally really looking how we address this. In fact, one task force, I can tell you, it's called the Trauma Informed Task Force for the state, and Department of Health has this, and I'm currently involved with it. We are looking at who takes care of the caregivers and ways that we can go ahead and make sure that caregivers are taken care of, because we are dealing with capacity issues at both the public and private sectors. So it's a very long-winded way of saying we recognize there are challenges.
Thank you. Sorry, I interrupted.
Not at all. important question, and an important ongoing discussion. And so bed space is ultimately going to be based on two things. It's going to be based on, one, facility, the number of buildings and structures, beds that you have, but you also have to have workforce that are available in order to be able to support clients who can make use of the spaces and those beds.
And I think too, in the interim, that's why this is a good collaboration. Because in the interim, because sometimes it may take a week or 2 weeks before these clients can be placed, and this might increase some mental health issues going on. That's where we can step in and having a crisis worker go out to these individuals, try to get them into the LCRS or one of our stabilization beds until maybe a bed can come open. And we just have to remember that this is not a substance abuse rehab, like going to the stabilization. It have to be a mental health crisis. But we do, we know most of these clients that's calling and trying to get into these treatment programs have dual diagnosis. So what we can do is address those mental health issues and help these individuals get into a safe environment, safe place, so hopefully they can get into one of these programs.
And another option as well, and it's case by case. If a client assesses at an IOP level, they're homeless, one of the alternatives would be searching for a clean and sober house that the client can be placed at. And that's something that the CSM, if the client is not linked with mental health services, that they can assist with. So it's being able to explore, get acclimated to all the services that is out there for the consumer, placing them at the appropriate level of care for stabilization and support.
So let me just go down the tree here. So if somebody needs help, mental health, substance use, anything, they call 988. And then they get triaged to about 4 different possibilities, including the 211 line and the substance use part of that line. Is that right?
No, the main number would be 832-3100. From there, our screeners would screen out what the crisis is, whether it's mental health or with substance abuse. So what we like to do is handle the mental health portion, make sure that we provide the appropriate services that is needed. And if they do have substance abuse, that's when we do a warm handoff to AUW to address the substance abuse. Should there be any crisis, it could always go back and forth, but it's a collaboration between 2 agencies to make sure that we provide all the services that the client needs for stabilization and support.
So just to add on to that, 988 is also appropriate as well.
Correct.
So it is new and up and coming, but yes,
Well, if I dial 988, will I get to 211 substance use eventually, maybe?
Yes, so 988 will get you to Hawaii Cares, and Hawaii Cares, as you now know, is Care Hawaii on the crisis side, and then AUW on the SUD side. So yes, you will get there.
And 832-3100 is Cares Hawaii.
Hawaii Cares.
Hawaii Cares.
Got it. Okay. And Leilani wants to clarify, if someone is on island and dials 988, it will go to Cares line who has an 808 area code. But if someone who has another area code, they need to dial Cares directly.
So that is correct. So how 988 works is it is based off of your area code. So if you do have clients or patients that have a different area code, say they recently moved from out of state, then they would be routed to, a different state, but they could simply say, hey, I just need to be connected to Hawaii, and they'll direct them back to Hawaii Cares. Or, if they can save 808-832-3100 on their phone. That's another way to do it. So that is the only hiccup with 988 currently. It is associated with the area code, but they're working on that, trying to get geolocation approved, but that's way down the line. So for now, this is what we got. So yeah, if you can educate yourself and others that that's how the system works, so they don't get frustrated or surprised when they get it answered from a different state.
Yeah, there's one additional thing that I do want to add, and I think this is really important. One of the things to understand is there really is a difference in terms of the services between Care Hawaii as well as Aloha United Way. So when you're looking at it in terms of, you have CARES as a whole, but then you also have Care Hawaii, which is handling mental health crisis. On the other hand, when you look at Aloha United Way, not only are they dealing with what could be called the SUD crisis, when Care Hawaii goes ahead and triages the calls and send them over, but there's also ongoing services that are provided on the Aloha United Way and SUD side. So for those who are considered, I guess you could say, returning customers or consumers, clients, they would not need to, and in fact, we would not want them or expect them to go through the general CARES line. The expectation is that in fact, they would go through directly through AUW. So I'd like to go ahead and turn it over to Jennifer and Josh for clarification. So Jennifer or Josh?
Yeah. A few slides ago, you saw how calls would get to us. So I just want to reiterate, and thank you for explaining that further, Dr. Euro. One way that this contract is different from previous version is that since we do have dedicated staff for substance use disorder, if they are already in the system and they are already in need of services, they could go ahead and just call 211 because they are in the system, and we want to make it easy for folks to access the SUD needs and services that are critical for a lot of our clients. If they're completely new and they do need some, that initial triage, Hawaii Cares is there 24/7 for that. But if you do have those clients who are already, in the SUD system, they could just go ahead and call 211. Thank you.
So I do want to emphasize that. So Jennifer has chatted in the box. And part of what we want to do is this really is about immediate access. So for returning clients, we don't want them to have to sort of repeat the same story because we know from the point of view of warm handoffs and access, often what can be frustrating for clients is when they feel they've gained access to the system to have to tell the story again. That's one thing we absolutely do not want to have consumers do. So as Jennifer notes, for clients who are returning, who've already been triaged and on the SUD side, already have received the services, they can dial 211 directly and do option 7. And then for providers who want to reach Aloha United Way, for consumers who are already in the system, already have been given the warm handoff to providers, they can actually dial option 8. And I'm looking at, yes, repeating the story and again from Renata, you're right. So part of what we want to do is once we get a consumer in, we want to make sure that there aren't extra layers. We want to make sure that, we can provide direct. So on the mental health side, it's a crisis. We want to make sure they're direct services. When it's an SUD crisis as well as ongoing services, again, we want to make sure direct access. And so that's how the two teams work together. And we also want you as providers, as well as we want your consumers to know that. We want to make sure that you have direct access, as well as repeat access, direct access to the services that are needed.
Yeah, thank you, Dr. Euro. And we're so excited to meet with you all. And, thank you for all the comments and questions. If we could do anything to support you all, like I know AUW has been meeting with a lot of our providers. So we're happy to meet if it's necessary, but we just want to say thank you for the time and opportunity.
Well, this has been wonderful. I remember when I thought the 211 number had gone away, and I was really sad because I loved the 211 line. So this is reinvigorating for me.
No, 211 is here. We are here.
Yay! It went away for a while though, right? Or
No.
No,
Okay.
we've been around since 1999.
Okay, yeah, somebody must have told me that it's closing or something, and I took that to heart. So here's kind of a mini case. Pamela asked, for the Hawaii Cares team, CMO and CSM services are open to anyone, correct?
Absolutely correct. And it's at no cost. So all of our crisis services are free to everyone.
All right, so then if they have SMI and need long-term case management, CCS service is only for Medicaid beneficiaries, right? And she's wondering what mental health case management services are available for those with SMI diagnosis, but not Medicaid eligible.
They will be ours. AMHD is a payer of last resort for all individuals who are uninsured or forensically encumbered or have public insurance, like say Medicare. We will service them.
Got it. Okay. And we had a request earlier for cards, information cards. We also have a request for flyers. So anything you can get us would be great. I know you're developing the cards now.
Yes, yes. So please reach out to me, and Kelly has my contact. So if you folks are wanting to get on, there is a list right now and it's building. But yes, we are working on getting those, and as soon as we have them in hand, we will be mailing them out.
And then we can put them on our webpage resources, and so people can pull them down if needed. And then let's see, for the LCRS, if beds are full, say in Big Island, are consumers ever transferred to other islands where there's a bed?
Unfortunately not. We try to, utilize our crisis mobile outreach to kind of stabilize in the community. We want to, because oftentimes what happens is when we fly folks off island or to another island and their crisis is stabilized, then it becomes an issue of how you get them back home. And we don't want to, displace folks that way, because that just creates a whole other crisis. So we do as much as possible, try to stabilize them on their island, in their community. The only exception, of course, would be like Molokai or Lanai, where we have an LCRS on Maui, and our CMOs on those islands will work with the providers to see, or with the health insurance as well, to see how we could get them to Maui for that service.
Great. And another question is, does the Medicare Advantage plans versus typical Medicare, does it matter for any of these services?
No, when it's, so it doesn't matter which Medicare, because Medicare doesn't provide case management. So, any of the health plans that don't provide that service, and the AMHD will provide it for them.
Got it. And Renata asked if specialists are flown in to help with clients for their particular needs.
Renata, can you kind of give an example of a specialist that you would?
Good question. That's kind of a mini case too. Let's see. Well, you said you take care of both kids and adults, so it wouldn't be a peds specialist. What are you thinking? Oh, child psych. We were thinking alike.
Right. So we do partner. So our other partner who isn't here in regards to the crisis side is CAMD. So we do have specialists. So all of our children, crisis mobile outreach and crisis services on that end is provided by Child and Adolescent Mental Health Division. So they've got expertise on that end.
And I heard that they were going to hire a child and adolescent psychiatrist on each island, except Lanai and Molokai.
That is the goal.
Oh, that would be great. Okay, so Renata says, how about developmental specialists?
So that is a very unique subset of consumers that we serve. We do have a crisis mobile outreach for DDD. Unfortunately, actually that Care Hawaii provides that service as well. With that one, it's particularly difficult because the person has to be an identified client of DDD. So that's, yeah, that makes it a little tricky. So if you do call Hawaii Cares, they will be able to link them to that DDD CMO. Unfortunately, Hawaii Cares doesn't know who belongs, who is a client of DDD. So, they can make that connection, but whether or not, they'll be provided the service because they're part of the client, if their current client is, unknown to Hawaii Cares when they're doing that transfer. So hopefully they are, but, and if they aren't, we hope that they do call back and Hawaii Cares will do their best with CMO to help engage the person and provide appropriate, linkage to services for them. But yeah, so we try our best with that one, with that group.
Okay, so I got a dumb question. I know there are no dumb questions, but Hawaii Cares and Cares Hawaii. Same thing, different things?
Different.
Different. Okay. So
CARES Coordinated Access Resource Entry System. So it is actually an abbreviation for what its purpose is. And I will go ahead and turn it over to Care Hawaii to explain the name really for their agency. It's so different. So go ahead, Brian, and your folks.
Okay. Well, Care Hawaii is a plethora of programs and services that helps the community in various different ways, from various populations like the DD program you mentioned, the SMI population, the EDAD or substance abuse population, as well as other youth services. So we've been around since 1999, and we did start off doing a lot of the children out of this and autism type services with the schools, and then we've grown to where we are now. We got the Hawaii Cares call center portion of this contract that we're working as a team with Aloha United Way to provide all the services that was mentioned today.
Randy says, I am thankful for the collaboration with Care Hawaii for some of my members in the Hilo area. And we've had some very nice appreciation in here. Let's see. Oh, they're so far back there. Anyway, and we had another question about veterans. Can veterans get the same benefits? Oh, we serve VA as well and try and link them to appropriate VA services. Great. All right, other questions? Well, this was wonderful and very timely. Dr. Euro says every Thursdays 2 to 3 is the CARES CQI.
CQI.
Yeah. You can contact the ADAD secretary and it's all there. So thank you guys so much. This was excellent. Last questions? Look up what's next week, Shar. Sorry so I promised some people yoga, but I think this was even more popular than yoga because this might be almost a record for us. I saw 131 at one point on the line. I think, Shar, do you remember, did we have 150 once upon a time?
Sorry, Charla.
But this
Anyway,
is the most
no.
in a long time. Oh, so next week we have borderline personality. So bring your borderline personality next week.
It's Dr. Westfall, so it's the part 2 to his presentation that he's doing.
Okay. Okay, wonderful. Well, thank you guys so much. And we look forward to the cards and any flyers you have. And this just seems like it's revving up our behavioral health help for people to the next level. So I'm really excited because we need this so badly. And so I'm very happy.
We want to say thank you so much for the opportunity to present. Not only that, but boy, just some wonderful comments, some great ideas, great questions. And we really look forward to working with all of you. And again, that's why I made the announcement regarding the CQI group. Everyone is welcome. This is where we get feedback for many of the suggestions that you provided today. And the best thing is you can show up as often as you'd like, as you would have time available. And this is a chance for us to learn and get better. But again, thanks for your attendance today. We all appreciate it.